Good afternoon, everybody. Today I'll be taking a class on assisted vaginal delivery of breech along with external cephalic version. The objectives of this class are the specific learning objectives: how to diagnose a breech presentation, how to investigate in case there's a case of a breech presentation, how to do an assisted vaginal delivery, and more importantly, how to do an external cephalic version of the breech so that the breech will deliver vaginally. The incidence of breech at term is around 3 to 5%, but at 28 weeks, if you see, the incidence is nearly about 25%. This is because of the amount of liquor which is present at 28 weeks. The baby swims around, so most of the time when they come for antenatal examination, it is a breech presentation. But at term, if you see, it is only about 3 to 5%. Now coming to the types of breech which are present, you have a complete breech and an incomplete breech. Complete breech usually you see in multigravidas with a lax abdominal wall. By complete breech we mean there is flexion at the hip joint, flexion at the knee joint, and also dorsiflexion of the feet. And this is seen in multigravida. Whereas an incomplete breech is seen mostly in primigravidas, wherein there is only flexion of the hip joint with extension of the knee joint. And among the incomplete breech you have the extended breech, wherein there is an extension at the knee joint, a footling breech where one of the feet is present beside the buttock, and a kneeling breech wherein the knee is felt on for vaginal examination. Apart from these types of breech, you also have the complicated breech and the uncomplicated breech. Complicated breech is one wherein along with the breech the mother has some other complication like diabetes or hypertension. Whereas an uncomplicated breech is one wherein the mother doesn't have any other complication except for the breech. Now coming to the etiology, you have the maternal etiology, the fetal and the placental etiology. Maternal etiology, it can occur in a grand multi, and because of the lax abdominal wall, it can occur in with the case of polyhydramnios, because the baby has wherein enough of liquor to swim about, and polyhydramnios, as you know, you have a lot of malpresentation. Oligohydramnios, it so happens that because of the less liquor, the fetus is not able to swim back to the original cephalic position. Then uterine anomalies, especially in unicornuate or bicornuate uterus, you can see a breech presentation, and presence of any leiomyomas or in a contracted pelvis. In fetal causes, you have twins and hydrocephalus, wherein the hydrocephalus, the head is the bigger part and it settles in the more wider upper pole of the uterus. Placental causes can be because of placenta previa. Habitual breech is one wherein a woman presents with consecutive breech pregnancy, and therein usually we suspect that it could be because of any uterine anomaly. Then coming to the diagnosis of breech. How to diagnose a breech? On per abdominal examination in the outpatient or in the wards, if you see, what happens is the fundal grip will be hard and ballotable, whereas the lower pole of the uterus, that is the first pelvic grip, it is broad and not ballotable, wherein the breech is present. Okay, and auscultation, when you auscultate, look at the fetal heart, it is always about the umbilicus or the maternal umbilicus. And per vaginal examination is more important because this is usually during labor. By doing a per vaginal examination, you will be able to make out whether it's a complete breech or it is an incomplete or a knee presentation or a frank breech. In a complete breech, beside both the buttocks, you are also able, in case it is a male fetus, you will be able to palpate the external genitalia of the fetus and also the feet by the side of the breech. That is a complete breech. Whereas in incomplete breech, only the buttocks are felt with the anus in the same straight line. So this can be confused with the face presentation, wherein both the malar eminences and the mouth of the fetus are in a triangle. So this is how you differentiate between a face presentation and a breech presentation. Breech presentation, all three are in the same line, same straight line, whereas for a face presentation, they form a triangle. Another presentation wherein you can confuse a breech with it can be a transverse line wherein one of the feet of the breech and the crook between the leg and the abdomen can be felt. In a transverse line also, between the axilla and the shoulder, at the axilla, if you palpate, it gives a impression like could it be a an incomplete breech. But what happens in this is you are able to in transverse line is you are able to palpate the gridiron feel of the chest, the rib cage. By that we can differentiate between an incomplete breech and a shoulder presentation. Now the investigations always teach that the routine investigations are important, but there is one investigation which you cannot neglect, and that is the ultrasound examination. And I always say that even ultrasound examination should be done even when the woman is in labor and you are sure it is a breech presentation. This is because ultrasound helps us to confirm the clinical diagnosis, and the most important thing is you will be able to diagnose a hyperextension of the fetal head. With a hyperextension of the fetal head, you cannot give a vaginal delivery. This mandates that we give the cesarean section, because with a hyperextended fetal head, it is very difficult to deliver a live fetus vaginally. Again, you can evaluate the fetal head and the thoracic girth, localize the placenta, and in case it is a placenta previa, again that goes for a cesarean section, and you can diagnose major congenital anomalies. That is the reason why even with a woman in labor, for diagnosing a hyperextension and also to rule out congenital anomaly, because there is usually breaches present with the congenital anomaly. So if there is a congenital anomaly, better to go for a vaginal delivery. Even a hydrocephalic head, if it is a gross hydrocephalus, we can still deliver it vaginally rather than give a scar to the woman and deliver a dead fetus. Better to diagnose it antenatally. Now coming to the positions of the breech presentation. Coming to the positions of the breech presentation, this can be a right sacro-posterior, left sacro-posterior, right sacro-lateral, but the commonest position is the left sacro-anterior, which you see in most of the presentations. And when we do a delivery also, left sacro-anterior is the commonest position which we can see. Now coming to the management of breech presentation, mostly it is during the antenatal period. If you diagnose a breech towards a term, it is for external cephalic version. As I have told earlier, when you look at around 28 weeks, you might see about 25% of the cases are breech presentation. But at that stage, we do not advocate external cephalic version. What is external cephalic version? By external cephalic version, we are trying to convert the breech into a cephalic presentation, so that, because why we want to do an external cephalic version is, by an external cephalic version we would have avoided a scar to the mother, that is a cesarean section can be avoided. And another thing is we can deliver this vaginally, but with the cephalic version there are certain contraindications which have to be taken care of. This is foremost is a twin gestation, and these are the contraindications. The antepartum hemorrhage, that is if a placenta is present at the lower bone, you cannot do an external cephalic version. Oligoamnios, obviously because there is not enough of liquor there. Any fetal anomalies, better not to do a version. And any cephalopelvic disproportion, also you cannot do an external cephalic version. Previous LSCS is a relative contraindication, but because of the presence of scar, usually it is a contraindication, and any IUGR fetuses cannot be subjected for an external cephalic version. Now, advantage is the timing better to do towards term, that is at 36-37 weeks it is better to do, because if you do at 34 weeks, because of the presence of liquor, the fetus might go back and revert to its original breech position. Then Spontaneous, in case of a fetal complication at 37 weeks, in case of there is any abruptio, or in case there is a fetal bradycardia, we are able to deliver the fetus vaginally and it is still going to be a mature fetus. Okay, so what are the prerequisites of external cephalic version? It should be a single term pregnancy, and you should know the fetal position accurately, whether it's a position is, whether it is a left sacro-anterior, that's the easiest position to do. Cephalopelvic disproportion to be ruled out, and you cannot do with the engaged presenting part because it's very difficult to dislodge the breech from the pelvic inlet, and intact membrane should be there, adequate liquor should be there, and maternal abdominal wall should be lax and thin, no placenta previa, and obviously no fetal anomalies. Then contraindications are absolute and relative. We have already gone through the contraindications. It can be a multiple pregnancy. These are the absolute contraindications, and the relative contraindications are the previous cesarean section, intrauterine growth retardation, history of any PIH, and obesity, or RH isoimmunization is a relative contraindication, because at the end of external cephalic version, at the start of it, you can give 300 micrograms of anti-D. And the procedure is, the woman, it's an outpatient procedure, and it is done without anesthesia. You have to empty the bladder, slight Trendelenburg position is given. You have to reconfirm the diagnosis by an ultrasound, and especially with the location. You have to be very sure of the location of the placenta, and in case it is an RH negative mother, please give anti-D. You hold with the left hand, the head of the cephalic pole of the fetus is held with one left hand, the other hand holds the breech, and you turn the fetus by 180 degrees so that the cephalic pole is present in the right lumbar region till the cephalic pole reaches the right lumbar region, and the breech in the left lumbar region, so that it's more like a transverse line. Then at that point, when the fetus is almost in a transverse line, stop, auscultate the fetal heart, and if there is no bradycardia or there are no decelerations, then only you proceed further. So that the next to this thing will be, you shift your hands, with the left hand holds the cephalic pole and the right hand holds the breech, and then you gentle nudging of the breech, you put the breech at the fundus of the uterus, and the cephalic pole, it will be the left sacro-anterior will become ROP or an ROT, that the head comes into the lower pole of the uterus, and that is the end of it. And then again you apply an abdominal binder, wait for some time, say look for the fetal heart, and then you can send the woman home, or again re-examine the woman 2 days later. Sometimes there is a reversion of the breech, or sometimes there is a failure of version, and the failure of version could be because of the fetus is large, or there is any fetal abnormality, fetal heart abnormality like decelerations or bradycardia, or because of the maternal obesity, or the uterus, you have not diagnosed a uterine malformation, or the breech has an extended legs, wherein like in a primary with incomplete breech or a frank breech, it becomes very difficult for us to do an external cephalic version. Now, when you are doing an external cephalic version, you should be aware of what are the complications. There can be a prolapse of the cord, a premature rupture of membranes, or a premature onset of labor, or there can be a placental abruptio placenta, or a fetal bradycardia, or a very rarely an unexplained fetal head, or the position achieved by the version may be worse than the original. That is, from breech you are converting it into a brow presentation. So these are all the complications which can be anticipated, but because of the complication doesn't mean that we should not do it. And all multis with a lax abdominal wall, this external cephalic version can be attempted. Now you have done the external cephalic version, the breech, you have been successful, then you go ahead and deliver it as a cephalic present. You keep an eye on the woman, you go till term, it is a cephalic presentation, you go till the 39 weeks or 40 weeks, you assess the pelvis, it's adequate, then she goes for a vaginal. In case you have not done an external cephalic version, or your external cephalic version has been unsuccessful, you have to think of assessment of a breech in labor. Sometimes it so happens that these days with the breech, most of the times, because the skills are not imparted, breech, you either they never had thought of, or the patient never had an external cephalic version, or she comes with a breech in labor. Then what are the factors we should consider to know whether we can give an assisted breech delivery or not? These are the age of the mother, the pelvic size and configuration, the weight and maturity of the fetus, the variety of breech, whether it's a frank, complete or a footling breech, the parity and the post-obstetric performance, then others like hyperextension of the fetal head. And last but not the least is the skill of the obstetrician, which matters very much, because now as the generations gone, less of breeches are being delivered vaginally, and these skills are not taught or not learned by the younger generation. Now, I always teach that as an intern or as a student in this thing, as an intern or as a junior postgraduate, you can definitely know whether this breech is going to deliver or not. And for that, this is one of my favorite scores, and most taught scores is ZA score. By this score, even you'll be able to say whether this is a case is for vaginal delivery, or definitely we have to do a cesarean section. For this, we need to know the parity. I mean, this is parity, gestational age, estimated weight of the fetus, history of previous breech, and the dilatation and station at admission of the woman. So parity, if it is a primate, it is a 0 score, multi gets 1 score, gestational age, term 0, then less than 37 weeks, it is 2. Estimated weight of the fetus 3.2 kgs, 2.5 to 3.2, and less than 2.5. Now, history of previous breech, none, 1 and 2. And cervical dilatation 2 centimeters or less, 3 centimeter or more than 4. And my this thing is, usually I give an example like if you are getting a multi with a gestational age of 37 weeks with an estimated weight of the fetus around 2.5 kgs, with a previous, suppose if she is a third gravida with a previous history of 1 breech, and the dilatation is more than 4 centimeters, station at admission is +1 or 0, then the score will be around 6, and definitely that score can definitely deliver vaginally. So this is what happens when if the score is 3 or less, definitely cesarean section. For 3 or less, most of the points when you try to estimate this, it comes on the left side of the table. But if most of the score is on the right side of the table and the score, ZA score is more than 3, then definitely she can be thought of for a vaginal delivery. Now coming to the management of labor in breech, either it is a cesarean section, that is what is happening in the majority of breeches these days, or it can give a vaginal delivery. Among the vaginal delivery, it can be a spontaneous vaginal delivery, an assisted breech vaginal delivery, or a breech extraction. A spontaneous breech vaginal delivery cannot occur unless the breech is an abortus of 28 weeks or the weight of the fetus is less than 1.2 kgs, wherein it just slips through the vagina. All breeches are assisted breech deliveries, that you have to remember. Even a preterm breech has to be assisted. There is nothing like a spontaneous breech delivery, or it is a breech extraction. But breech extraction is nothing, but it is done only after. In modern obstetrics, breech extraction has a place only after internal podalic version of the second twin. After a cephalic delivery, in a twin gestation, after internal podalic version of the second twin, in case of a transverse line, then you can go for a breech extraction. Otherwise, breech extraction is obsolete in modern obstetrics, and what we do is only an assisted breech delivery. When you are doing a vaginal delivery, it is only a assisted breech delivery. Now coming to the indications for cesarean section. Elective indication: elderly priming, history of infertility, bad obstetric history, cephalopelvic disproportion, intrauterine growth retardation, placenta previa, or prolapse of the cord, or a large baby, or hyperextension of the of fetal head, or a breech score of 3 or less with the Zashev-Andrews score. All these definitely warrant a cesarean section, and these are all for elective cesarean sections. Now coming to the cesarean section rate, it is almost till 70 to 80%, 15 to 50% is very much less. About 80 to 85% of the breeches deliver. And this is if the woman is caught in the antenatal period. Only vaginal delivery is given these days for breaches only if they come in labor. So 80% of the cesarean sections are elective, and even for those women coming in labor, if they come early in labor, most of the breaches land in only an emergency cesarean section, because the practitioners of the art of assisted breech delivery are becoming less and less. Now, indication for cesarean section in breech, emergency. What we have so far taught is the elective indication. Emergency indications can be a prolapse of the cord, especially fifteen breech 15 to 18%, complete breech 4 to 6%, and a frank breech up to 5%, or a premature rupture of the membranes more than 12 hours, or in case of fetal distress. These are the indications for emergency section, cesarean section. Now, coming to the vaginal delivery in breech, what are the criteria for trial of labor? This criteria for trial of labor can be an estimated weight of 2.5 to 3 kgs and BPD less than 9.5 centimeters by ultrasound, flexed fetal head, adequate pelvis, no maternal or fetal indication, and breech score of 4 or more by the Zashuni-Andrew score. Fetal heart to be monitored, a partogram to be done, and no heroic vaginal procedures are to be done. Mechanism of delivery, as usual, mechanism of delivery, first is engagement, descent of the breech, internal rotation, lateral flexion, external rotation, and birth of the breech. Whenever you are describing a breech delivery, you should deliver, first talk in terms of delivery of the breech, delivery of the shoulders, and then last is the delivery of the aftercoming head. Now, delivery of the breech, first this thing, commonest position, as we have already taught, as we have already said, is the left sacro-anterior, wherein the sacrum is pointing towards the anterior this thing, and the bistrocantric diameter, engaging diameter is the bistrocantric diameter of the fetus, which is around 10 centimeters, and the denominator for a breech presentation is the sacrum. And descent occurs, and with the descent, in a normal labor, we talk of internal rotation, we talk of flexion, descent with increasing flexion, but here it is descent with increase in compaction, wherein lesser and lesser degrees of the fetal breech is presented at the into the cavity of the pelvis. Then internal rotation. Internal rotation, if you compare with the, it is more easy to understand this if you remember your steps of the mechanism of labor in normal labor by the cephalic presentation, the vertex presentation. Here internal rotation, there the occiput is moving by about 1/4 of a circle, but here by internal rotation, the anterior buttock, here it is not the sacrum which moves, but it is the anterior buttock which moves and hinges against the symphysis pubis. Here you are seeing that the breech has come, the anterior buttock is under the symphysis pubis, and then next what happens is the lateroflexion of the breech, and usually the breech is delivered by lateroflexion. Here if you see, it is the lateroflexion and the breech has delivered. What we are telling is only the mechanism of the breech and not how to conduct the breech delivery. Then after the breech, it is the next turn of the shoulders. Shoulders again engage in the same, it is the bis acromial diameter, which is the engaging diameter for the shoulders. The shoulders engage in the same oblique diameter as the breech, and the breech descends, and there is engagement, descent with increasing compaction, internal rotation. By internal rotation, the breech moves forward by 25 degrees. Then after internal rotation, the anterior shoulder hinges against the symphysis pubis, and because of the inclination of the pelvis, the posterior shoulders enters into the brim of the pelvis, the cavity of the pelvis ahead of the anterior shoulder. If you can see in this figure, the anterior shoulder is slightly higher than the posterior shoulder, and then there is a delivery. Next, after the delivery of the shoulders, you come to the delivery of the head. Here the head engages in the opposite oblique diameter as the breech, and here it is the suboccipitofrontal diameter, which is the engaging diameter, and again there is descent by increasing flexion of the head, and then there is internal rotation, engagement, descent by increasing flexion, then internal rotation. By internal rotation, the occiput comes and lies below the symphysis pubis, and the birth is by flexion of the fetal head, wherein the chin, the mouth, nose present, and last to be delivered is the occiput. Now, what we have spoken so far is the delivery of the breech by, the mechanism of delivery. Now we will come to the delivery of the breech. The delivery of the breech, first stage essentials are observant how to conduct a breech labor. First is observant expectancy, supportive therapy, absence of interference, rest in bed. Then IV access should be there, and you should not go on doing a frequent paravaginal examination. And meconium, because the lower end of the fetus is down, definitely you're going to see some meconium. Meconium should not be a cause for alarm as long as the fetal heart is not. Then say the personnel who are required at the second stage of labor, the personnel who are required, the position of the woman, bladder to be catheterized, IV lactate with oxytocin to be started. Equipment, definitely you need a dry warm towel. And then equipment for episiotomy, Piper forceps, decline chain. Piper forceps, equipment for resuscitation of the infant, and then anesthesia, which is you can give a local block, and an episiotomy is mandatory for all abnormal deliveries. Then fetal landmarks, anterior buttock, pural block is to be given, and again when you see the bead of meconium, that is when the breech is at the as you give an episiotomy during crowning and you see the breech climbing up, an episiotomy is to be given. When the posterior buttock is seen, just hands off. When the hips are seen, deliver the legs. At the umbilicus, gently pull a loop of cord down. The scapula, when you see the scapula, deliver the arms, and when you see the nape of the neck, deliver the head of the fetus. Then this is how you conduct the breech delivery. Episiotomy is already given, and the legs are, if in case of difficulty of delivering the heads, the legs you can use the Pinard's maneuver. And then next is the delivery of the shoulder. The posterior shoulder is delivered ahead of the anterior shoulder. Then delivery of the aftercoming head. It can be either by, you allow the breech to hang down by its own weight. That doesn't mean that you move away. You hold the fetus and you just, and always the breech is to be held by the feto-pelvic rib and not anywhere else, because you'll end up damaging the soft parts of the breech. And this is the Burns-Marshall technique which you are seeing, and which you are seeing to deliver the aftercoming head. You hold the obstetrician holds the feet of the fetus and delivers it onto the mother's abdomen. And next is the best way to deliver the aftercoming head of the breech is the applying forceps. Then you can also use the Mauritius, and this is the application of the forceps, wherein the fetus is held up and the forceps are applied down, and then by locking the forceps you deliver the fetus. Then after that another method of delivery of the fetal head, in case of difficulty of delivering of the fetal head, it is the Burns-Marshall. The routine method is Burns-Marshall maneuver. Here we are seeing you hold the feet of the infant between both the between both the fingers of the right hand. Then it is swept over to the mother's abdomen and delivered. That is the Burns-Marshall method. Another method of delivering the breech head is by using the Mauritius-Melny-Wyatt maneuver. This we usually use wherein there is difficulty in delivering and the head is still not into the pelvic inlet. We use this maneuver. The operator's arm is on the left arm, the fetus is held astride, and with the right arm, one finger underneath the suboccipital region, it is pushed up, and both the other fingers of the the obstetrician's hand are on the shoulders, and flexion is given by an assistant from above. You deliver the fetal head. This is used only when the nape of the neck is not seen and you suspect that the breech is in the aftercoming head is still not within the pelvic cavity. Then this is for the management of the complicated breech delivery. The rest of the breech can be at the breech level, or it can be at the shoulder or arms, or at the aftercoming head. And then for a breech impacted low in the pelvic floor, you can do you can do The causes can be an extended legs, an outward contraction, or a rigid perineum. All these can be gotten over by doing a Pinard's maneuver or a traction with finger in the groin. Then the next thing is what we do is a Pinard's maneuver, where two fingers are introduced along the breech into the groin of the fetus and try to deliver the breech. And Lovesit's maneuver is usually used wherein there is difficulty to deliver the shoulders. And the principle is we take advantage of the fact that the posterior shoulder enters into the cavity of the uterus ahead of the anterior shoulder. The posterior, there is a 180 degree, you turn the breech by 180 degrees and then you try to deliver the fetus. Then management of a complicated extended arms, you can do bring the posterior arm down. Or nuchal arms also, you use the cat paw, as if the cat is cleaning the face, and you try to deliver the head. Then difficulty with the after coming head, it can be either a flexed or an extended. Flexed head, you use the, we can use the, in case the breech is unattended from before and the ventrum of the fetus faces the obstetrician, you can go for the Prague maneuver. Then arrest of the after coming head at the breech, brim and the cavity, you can deliver if it is a deflexed head or a contracted pelvis or a hydrocephalus. These can be the reasons for the arrest of the head at the brim and the cavity. At the outlet, it could be because of the rigid perineum or a deflexed head. Then management of, in case there is an insufficiently dilated head, you can go for the Duerson's incisions and dilate the cervix. And breech extraction, as I have said, it is done only for, in modern obstetrics, you can do only for second twin in a transverse leg. So these are the pictures of the breech extraction. Now the prognosis in breech presentation or the damage which can be done to the breech is, there can be a dislocation of the shoulder or a prolapse cord or a dislocation of the hip joint. That is why what we teach you, whenever you are delivering the breech, always the dorsum of the breech should be facing us, and the breech always should be held in the feto-pelvic dimension. No hand should be kept anywhere else except on the pelvis and the fetus. By the feto-pelvic grip the breech is held, and that is how you deliver.